Good afternoon, and thank you, Dr. Anaga, to have asked me to participate in your course. It's difficult to speak after Dr. Suhas, who's been a teacher to all of us for so many years, a brilliant teacher. So, I'm going to discuss some basic mistakes that make our patients unhappy. To some portion, it is the neuroadaptation of the patient, which we always like to blame, and to some portion, it is us. So, I'll try to clear our part. Today's premium life, certain things are a necessity, as Dr. Anaga said about immersion biometry. I think contact biometry should be banned. You should never do contact biometry. Either you do immersion or you do optical, but do not do contact. So there are advances in ophthalmology like flax. We have advancement in biometry. We have better formulas and we have better IOLs. So everything is favoring us besides having a good surgical technique. So it's a very old saying that if I had 1 hour to solve a problem, I'll spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. So it's always better that we spend little more time about how to do it. So do not bargain here. So you have to have proper patient selection, preoperative counseling, a good surgical planning, a preoperative management, and of course, management of expectations. Today morning, I attended one course where it was a very good take home message that when you are counseling a patient for a multifocal IOL, make sure that you develop a rapport with the relative who comes with the patient. We are normally focused on the patient, but I think we have to have a bimanual focus. So one is focused on the relative because what happens is on the counseling day, the brother comes, and on the surgical day, the father comes, and the father doesn't know anything what has happened in the counseling, and there's complete chaos. So I think this may be a good idea that we concentrate on both. So preoperative homework, do it yourself, test refraction of both eyes. So if there is disparity, you'll come to know. See what the patient is used to reading, what distance the patient wants, helps to know what range that he really wants, and whether he wants to drive at night or not. Slit lamp examination is all the same. Tear film assessment is important. If it is subminimal, make sure that the tear film meibomian gland analysis is done. Endothelium analysis is important. Pupil size, centration, and angle kappa you have to note. Pupil size is important because if the pupil size is very, very small and you put a EDOF IOL, you are going to be unhappy because patient is not going to get any effect. Another thing to know, photopic size of the pupil and the scotopic. Luckily, being in India, our pupils are not large. So what I do is, how do you measure photopic and scotopic? What we do is we have a wavefront analyzer, cover the head of the patient with a black cloth, and then take a measurement. That's the maximum pupil that that patient is going to get. And the same technique I use in LASIK, and my optical zone is decided according to that size of the pupil. Corneal topography is very, very important to know your maximum peak, know your keratometry, whether it's regular or irregular, know your white to white, make sure that the patient does not have any dystrophy or a band degeneration at the level of the epithelium. And astigmatism is very important that the patient has to be counseled for a toric IOL if necessary. Of course, knowing your retina, if the patient wants a multifocal IOL, there is no doubt that the patients should not have an epiretinal membrane, should not have some aneurysms or exudates around the macula, and we have to do an OCT macula to know that there is no edema. So rule out all the problems. So basically, look at all the red flags as far as multifocality is concerned. So high demanding patients who wears glasses for even small refractive errors, we are the people who will chew your brain up. Okay, particularly animated cataractus, severe dry eyes, knowing high order aberrations at the cornea. We normally tend to ignore this, but it is said that the cutoff is zero point 0.5 microns. So if the high order aberration is very high, avoid a multifocal IOL. Look at angle kappa, which is more relative in a hyperopic eye and not so relative in a myopic eye because it does not play any role. Astigmatism, inaccurate biometry, Barrett universal formula. So using the right formula, having the right biometer, which normally we have two optical biometers and both are doing extremely well. Refine your nomogram and make sure that you know that your SIA is good or not. So normally now we all consider our SIA as 0.1. Negative dysphotopsia patients are going to be unhappy. They'll say that they see an arc on the side. Post-operatively, if the patient has blurred vision, you look at everything. You look at whether the patient needs any refractive errors. So there was a mistake in your biometry. Look at IOL centration. If a multifocal IOL is decentered, the patient is going to be unhappy. And of course, if there is a PCO, some patients do develop a PCO very early, then the patient is going to be unhappy. So some part I'll tell you about calculation, which I learned over time. What is a good candidate besides ruling out the red flags that I told you? Pre-op planning and technique is equally important. So check every level that you're not making a mistake in any of these levels and any loop that you're missing out. Logical stepwise approach helps in the frame of problem, taking the right steps toward the right solution. And some patients may need an exchange at a later date. I just want to give one example of a high level of toric IOL calculation, which we did. So I have an anterion and I have a lens star. This was a little VIP patient who needed IHANS toric. So in fact, I was the first surgeon in India to implant an IHANS toric much before it officially got launched. This person worked for a very high level company, so he could manage to get the lens in. So you can see that the patient does need. So I've done a pentacam, I've done an anterion, and I've done an IOL master. Okay, and let us look with everything works and all the formulas are matching or not. So you have to do, so we do 4 formula calculation for each patient when he needs a multifocal. You can do SRKT, you can do Barrett, and you can do Barrett Universal, and of course Hill RBF. You can have an optical biometer. So here, as per the Hill RBF reading, I need this, and according to the IOL master, you need this. So I've here compared 2 optical biometers. Both are needing the same amount, and the end result is almost the same. So toric calculation went the same way and it worked very, very well. The post-op patient, so here I can show you my sheet. There's an anterion, there is a lens star, there is an immersion if necessary, and you can do calculations according to the formula you want. Ultimately, I used an IHANS toric and the patient was very, very happy. But one important mistake where we can make is knowing the ACD. Now, many people do not know this, that ACD plays an important role in effective lens position, and so the cylindrical power at the corneal plane can really change. So there was a study done long time back that if you have a deep ACD for a given toric IOL will correct a lower amount of corneal cylinder than the one with a normal ACD. Conversely, in hyperopic eyes, the same IOL will correct a higher amount. So when you have a toric IOL, do concentrate on the ACD. If your ACD is just an example, important to consider hyperopic ACD of 2.54 and you are calculating toricity, you will have 2 different formulas with 2 different toric powers. So which one will you select? So without ACD and with ACD. So you can see that the whole lens actually changes from a 2.25 to a T3 while considering the ACD. So some studies have said that it really doesn't matter, but whatever little experience I have, that it has said that it's better to look at the ACD when you have a toric IOL and the calculations are much more accurate. So posterior corneal astigmatism as far as multifocality is concerned is also very important. Previous calculations we did not bother about this, but now if a patient wants multifocality, besides doing your routine retina, cornea, high order aberrations, also look at posterior astigmatism. And many studies have found that posterior corneal curvature varies amongst different individuals. So ignoring it completely will give a wrong result and make the patient unhappy. We also know that with age, the anterior astigmatism moves horizontally, but the posterior astigmatism is really not affected. So the posterior corneal astigmatism will compensate anterior corneal astigmatism in a younger population. So we also, just to put it very simple, don't get confused by all this. If the patient is with the rule astigmatism, undercorrect by 0.5, and if the patient is against the rule astigmatism, correct it completely. Okay, just remember this and that should be fine. So anterior corneal surface which is in contact with air has a positive refractive power, and the posterior corneal surface which is contact with aqueous has a negative refractive power. Hence, a vertically aligned steep meridian on the posterior corneal surface generates against the rule, that is, and that neutralizes some part of the corneal astigmatism, and it's exactly opposite when it comes to the posterior. Just a simple example, that if the meridians of the anterior and posterior corneal astigmatism are the same, posterior corneal astigmatism reduces the anterior corneal astigmatism as it neutralizes it. And if it is exactly other way around, it will increase your astigmatism. So just remember this, that do not ignore posterior corneal astigmatism. Look at it and look at it for your calculation. Just one example here, I've got a femtorexis. If you are having a femto, believe you me, it's like if you don't have a Lamborghini, you don't know how the car drives. If I had my own eye to be operated, I would 100% select flax. Not saying this because I have it. I'm saying this because it has phenomenal advantages. Flax can make your incisions. Flax makes your CCC perfectly on your visual axis. I also know that the IOL centers in the center of the bag, irrespective of where you make your rexis, but having a perfectly round rexis can also have a rescue phenomena. So if you have a PC rent, the CCC will really help you to save your IOL, and you can do a reverse optic capture. So you can see a trifocal IOL going perfectly into the bag, and it centers automatically. When you do a manual CCC, you have to nudge the lens to center it. But when you do a CCC through flax, it automatically centers, And it's very important to remove the viscoelastic from behind the IOL as far as multifocal IOLs are concerned. So these are simple things that you have to look at calculations. So in conclusion, a good pre-op examination, a surgical process which has to be perfect, and a post-op looking at your results and analyzing what your SIA, etc. is will make a patient very happy. Thank you.